Good morning, I'm Anna Nolte, and we're back to interpretation of the CTGs. You have already interpreted 3 CTGs before, so I'm sure you know exactly what to do and how to go about. You have already completed your quiz. You have already see what you have done wrong or right. And now I'm just going to go through this, interpret the CTG for you and go through it with you. And then we're also going to look at the figure guidelines and the NICE guidelines on how to classify this. And we will also talk a little bit about the management of the slide, of the CTG. This is the CTG that you had in front of you. So I think you have gone through it already carefully. So let's look at the interpretation. Now, I hope that you can see on this slide clearly, but if we draw a line, we have said, and I'm just going through the definitions of all these things again for revision, we have said that the baseline is the average heart speed of the fetal heart between periodic changes. So in other words, between decelerations and accelerations. So if we draw a line here through this basic, the average heart rate of this fetal heart, then we see that it comes to more or less 110 beats per minute. There you can see the 110 beats per minute. Now, the variability, the definition that we have said is the variability of the fetal heart rate. The fetal heart rate varies all the time, and we have said that there are two different ways in which you can determine the variability. You can either draw a line, also again between periodic changes, a line at the bottom of this fetal heart and a line at the top of the fetal heart, and see then the range of the fetal heart. Or you can also look at how much variation was there from that peak of the fetal heart to the bottom here, and we can look at the range there, and we can look at the range there, and we can take an average. I usually use this method where I just basically draw a line or take a ruler and look at where's the bottom of the fetal heart and the top of the fetal heart. And in this case, we can see that the variability was 40 beats per minute. Now we know that the normal variability for the fetal heart is between 5 and 25 beats per minute. So a 40 beats per minute variability will definitely be an increased variability. Now, if we look at accelerations and decelerations, now it might look like these might be accelerations, but if we really look at the definition of acceleration and a deceleration, we've said it's where the fetal heart rate accelerates with more than 15 beats per minute, or decelerates with more than 15 beats per minute. And we see that this is not really an acceleration, and here we can see it's basically more variability of the fetal heart than of an acceleration. So we say no, there are no accelerations and there are no decelerations. If we look at the contractions, the frequency of the contractions, we see that this is a 1 centimeter per minute graph. Then we see that from this row of numbers here to this row of numbers is 10 minutes. So if we look at, there's 1, 2, 3, 4, 5 contractions during this 10-minute period. Now, if we look at the classification, how can we classify the CTG in terms of the figure guidelines and in terms of the NICE guidelines? Then we see, if we look at, and this is the figure guidelines that you have here in front of you, if we look at the baseline, we see that the baseline is normal. It was 110 beats per minute, so it falls here within the normal block of the FIGO guidelines. If we look at the decelerations, if we look at the variability, we see that there was increased variability. So the variability falls here under the pathological column. There were no decelerations, so we say that the decelerations fell here within the normal column. So if we look at this, the baseline was normal and that there are no decelerations, but the increased variability put this fetal heart rate here under the pathological column. So we say that if we interpret this now, we say that there's a high probability of hypoxia because of this increased variability. And the clinical management, according to the FIGO guidelines, is immediate action. And we will look at the immediate action in much more detail just now. If we look at the NICE guidelines, now the NICE guidelines, if we look at the baseline again, it was normal. They say here that their normal variation is between 100 and 160 beats per minute. So our baseline was normal. The baseline variability, they say it's normal if there's 5 or more. They don't have an increased variability on their guidelines. So they just talk of 5 or more, or it's non-reassuring when there's less, and also when there's less. So they don't have anything about increased variability on their guidelines. And then also there were no deceleration. So according to the NICE guidelines, this fetal heart rate, this CTG pattern would have almost been a normal one. Now we know from theory that increased variability is a definite sign of hypoxia or a possible hypoxia. So even though there's not increased variability on the NICE guidelines, I think that one should still treat it as if it is there's the possibility of hypoxia. Now the question next one is the most significant type of hypoxia indicated in the CTG, and usually in the case of increased variability we talk about subacute hypoxia. Remember, we have 3 categories of hypoxia. We have chronic hypoxia, that's a hypoxia that develops gradually. Then we have an acute hypoxia where the hypoxia develops very quickly, but then we also have a subacute hypoxia that's almost in between the two. It's not chronic and it's not acute, but it is developing in between, and that's we usually get that when we get increased variability. And is purely observational management appropriate now? No, because we have said this is a hypoxia, so we need to treat this hypoxia. And the management of the hypoxia based on the FIGO guidelines, because we have said that there's no increased variability on the NICE guidelines, so we work in this case on the FIGO guidelines. And we have said on the FIGO guidelines it was a pathological trace. So according to that then we will start with resuscitative measures, which we will come to just now, to improve the uteroplacental perfusion, so immediately, and then make preparations for delivery. And then if there is improvement in the fetal heart rate or in the fetal heart condition, obviously we will just observe it very carefully. But if there's no improvement in the fetal heart rate tracing, obviously the delivery should be expedited in the form, depending on whether the patient is fully dilated or not, in the form of a instrumental delivery or a cesarean section there. Now, I think we have talked in all 3 previous slides on in utero resuscitation according to the maternal guidelines, and I will just go through them very quickly. As I've said, we have talked about them many times now previously. So first of all, one will perform a vaginal examination to exclude cord prolapse and to also determine what the cervical dilatation is. Obviously, that influences the way in which the labor will be expedited. If the patient is fully dilated, obviously the labor should be expedited by means of an instrumental delivery, as I've said, or if the cervix is still not fully dilated, by means of a cesarean section. The mother should be repositioned so that the blood flow to the uterus is maximized, and basically a left or a right side is best. The administration of oxygen, as we've said also previously, is controversial. Many people think that it shouldn't happen. If it is necessary, one can give oxygen at the 6 liters per minute via face mask for approximately 20 to 30 minutes. If it doesn't help after 20 to 30 minutes, it will not help. So it's not necessary to continue on and on and on and on with oxygen. The reasons why we've said that is that fetal compromise is seldomly caused by maternal hypoxia. If there was maternal hypoxia because of a heart condition, maternal heart condition, or something like that, we could continue with that. Otherwise, not. Or hyperoxemia can have adverse effects on the fetus. We have said that it can also cause eye damage, and that it also causes the release of radicals that might be have a negative effect on the fetus. And as I've said, once the variability has been recovered, the oxygen can be stopped. Now, also to improve the blood flow between the placenta and the fetus, we put up an IV fluid with Ringer's lactate, preferably because it expands the blood volume of the woman, except if she's hypertensive, obviously. And then also improve the placental perfusion in the case of hyperstimulation, when the uterus is overstimulated, in the case of where the mother is induced with prostaglandins or oxytocin, it obviously has to be stopped immediately. We can reverse the work of the oxytocin and very quickly by just stopping it, but prostaglandins we can't really reverse quickly because it's mostly in the mother's blood circulation, and it takes longer to the half time of prostaglandins is much longer than that of oxytocin. So if we have to stop the contractions, or also to improve the placental perfusion, and we do that by giving the mother tocolytics, and to see if when the contractions are being stopped, whether the condition would improve. And obviously, we need to explain this condition to the woman. And that's the end of this lesson. I hope that again you've learned something about the interpretation of the CTG. Or if you had been correct, all your interpretations were correct, then you can pat yourself on the shoulder. Okay, bye-bye.